Welcome to Professor Molly's series on heart failure. All right, what is heart failure? Well, our heart is our lifeline to our body. And when your heart isn't pumping correctly and there's damage to that heart muscle or it's weakened, it's not going to allow enough blood to pump forward to meet your body's need. And this is going to result in a decrease of your cardiac output. You're going to have actually a decrease of your oxygenation and your tissue perfusion. And you're going to see a decrease to your kidney perfusion as well. And what we're going to do is we're going to break it down from the left side to the right side. We're going to talk about the signs and symptoms of each sided heart failure, the causes, diagnosis, and interventions, and how we're going to try to identify and fix the problem. So to really understand heart failure, you have to understand the anatomy and the blood flow of the heart. So we're going to just review it. So your blood that's deoxygenated is going to return to the heart through the inferior and superior vena cava. It's going to dump into the right atrium, go through the tricuspid valve to the right ventricle. The right ventricle is then going to send the blood to the lungs through the pulmonary artery so it can get oxygen. After it gets oxygen, it's going to dump back into the left atrium through the mitral valve to the left ventricle. And then the left ventricle is going to pump. It's the biggest chamber. It's going to then pump through the aortic valve to the rest of the body to supply the body with oxygen. Now, if you have left-sided heart failure, what you're going to see is your blood is not going to actually be able to pump forward. You're going to have a decreased amount of blood pumping forward to the rest of the body and perfusing the body. So your cardiac output is going to be decreased. And then you're going to have a backup of fluids because the oxygenated blood from the lungs is not going to be able to pump out. So it's going to back up into the lungs. Now, your right side heart failure, the blood that's trying to come back from your body and dumping in that's deoxygenated, that's going to back up. So when right-sided heart failure, you're going to see a backup in the body, and you're going to have the swelling and edema in the body versus really the lungs on the left side. So when we talk about the signs and symptoms, I hope that makes sense when you think about how the blood is pumping forward. So again, blood is not able to pump forward on the left side to the body and will back up in the lungs. On the right side, heart failure, your blood is basically not able to pump forward through the lungs and is going to back up into the body and backing up into the right side. Okay, so left-sided heart failure, what is it? Well, this is when the left side of your heart has become damaged, the heart muscle is damaged or weakened from a heart attack, from acute coronary syndrome, or from coronary artery disease, and that heart muscle is weakened and damaged, and it can't contract enough to squeeze the amount of blood out to the rest of the body. So that is a decreased cardiac output. And what happens is if you can't squeeze enough blood to get to the rest of the body, which is oxygenated blood, you're not going to perfuse the organs, the tissues, your brain, your kidneys, and you're going to result in complications of decreased oxygen demand on those tissues and organs, and it's going to lead into organ failure. So the left ventricle has to squeeze enough to get the blood out, but if it doesn't, it's going to back up. And if the blood backs up into the lungs, it's going to present as respiratory signs and symptoms. So the patient's going to be short of breath. They're going to have trouble breathing. Their heart rate's going to go up because their respiratory rate's up. They may be restless and confused. They will sound wet. They will have a cough and crackles and rales in their lungs. They will also have a decreased oxygen saturation. If you see a pink, frothy, blood-tinged sputum, this is a presentation of pulmonary edema. Also, orthopnea and nocturnal proximal dyspnea, these are problems when patients lay flat. What happens is the fluid settles, and at nighttime, which is the nocturnal part of it, if they lay flat, then also their respiratory rate decreases at night, their adrenaline, of course, decreases at night, and these people feel like they're suffocating and can't breathe. So they will typically need to sit up and either go to a window, get a fan on them to feel like they can catch their breath. They're going to feel like they're drowning. Okay, so right-sided heart failure, what is that? Right equals rest of the body. So what happens is that right side cannot pump forward. That right ventricle cannot pump into the lungs. And then the fluid that's trying to come in from the rest of the body is going to back up. And this is caused by damage to that heart muscle, either from left-sided heart failure, because if that left side is not able to pump, remember we said it backs up into the lungs. Well, if the lungs now have higher pressure, that right ventricle is going to have to push harder, and that's going to then back up and leading to right-sided heart failure. So typically people with left-sided heart failure that's not treated, they'll start to develop right-sided heart failure along with their left-sided heart failure. But also people with pulmonary artery disease, pulmonary heart disease, things like cor pulmonale, things like pulmonary hypertension, this can cause an enlarged right ventricle, and that is due to increased resistance and pressure in the lungs. So that is having a hard time for the blood to pump out to the pulmonary artery. And so this can actually cause right-sided heart failure. Also, diseases of the lungs like COPD, also patients with sleep apnea can develop right-sided heart failure. And so when blood backs up into the venous system, they're going to be having signs and symptoms of swelling. And that is the biggest hallmark sign of right-sided heart failure is swelling and edema and weight gain. So typically, if you have a weight gain of more than 3 pounds in a day, that is not good. Or more than 5 pounds in a week, you're retaining fluid. And so that is going to start showing in your body. You're also going to start seeing that if you are looking at their neck veins, their jugular vein, they will start having a bulging in their jugular vein in their neck, and that's jugular vein distension. They could start developing irregular heart rates. They will also be fatigued. And if you're monitoring their CVP, so their central venous pressure, that right atrium pressure, we talked about that right side, that is actually going to be increased. So typical CVP runs around 2 to 8. And if it's anything greater than 8, you're going to have an increased CVP. So when fluid and blood backs up, it's going to cause organs to be overloaded because the blood is not moving forward, okay? It's backing up. So those organs, including your liver, your spleen, they're going to actually be enlarged. And so you're going to start seeing ascites, and you could probably develop hepatomegaly or also splenomegaly with this. Okay, so now let's dive into how do we diagnose heart failure. And I listed a few more causes, and we're going to get in the interventions in a minute, but we're going to focus on the diagnostic studies. So the echocardiogram is a test that's going to measure the size of your heart, the valve function, the wall thickness, and the ejection fractions. That's the EF percentage of your heart. How much blood is being ejected out every minute. Normal is 50 to 80%. And then you can actually have a normal EF, or you could have a low EF. A low EF, less than 40%, is going to show a typical systolic heart failure. And the difference between a systolic heart failure and a diastolic heart failure is just how the heart works. Systolic is when the heart contracts and squeezes. And so if you are in a systolic heart failure, your heart is not going to squeeze and contract enough to get that amount of blood out. So the amount of blood that's getting out is less than 40%. Now, in the diastolic phase, your EF will probably be normal. So what you'll see is that's the relaxation phase of the heart. So typically the heart in a diastolic heart failure will not be able to relax fully. The amount of blood that needs to be pushed out, the contraction's still there, but it still won't be able to hold the amount of blood because the wall of that ventricle is thicker, and so that might be a diastolic heart failure. So when you do an echocardiogram, you not only get the ejection fractions, but you get the wall, the size of the heart, and then the provider's able to put the interventions based on what they see to help fix not only the systolic or diastolic part, but also if it's right or left side heart failure. So that's getting a little bit more in depth, but I wanted you to know why and what they were measuring with an echocardiogram. Now, a BNP is the lab value I want you to know on this one, because the BNP is a hormone that's secreted when the pressure is high in the ventricle. And you typically want to see a BNP less than 100. So when you start getting above 300, your volume in your heart, the ventricle, the pressure in your heart is higher due to the volume. So the higher you go, the more volume and pressure in your heart. So when you get over 900, that's pretty severe. So you definitely want to treat this. And again, we're going to get into the interventions in a minute, but how you treat it is based on the lab values that you're going to see. Okay, so now let's go on to interventions. Now we're going to use the acronym HOPE, which is HOPE, to help us remember our intervention. So H, head of the bed up. These are patients when they come in, you can ask them, how many pillows do you sleep with at home? And you're going to find that they actually may sleep with a few pillows or they may sleep in a chair. So these patients will want to be elevated. So the biggest thing you need to do, respiratory, they're going to have a respiratory distress. They're going to want to be sat up. So sit them in a semi-Fowler's, 30 to 45 degree or higher. Now, oxygen, when we talked about their oxygen need, so if their blood is not pumping to the rest of the body and not getting to the body to perfuse the organs, that is a decrease of oxygenation and tissue perfusion. They're going to need supplemental oxygen. So giving them oxygen, monitoring their oxygen saturations with their vital signs is very important. So giving them and keeping them above 92% is very important. We're also going to be pushing meds. What's going to happen? Why are we going to give them all these meds? So when somebody's in heart failure, remember they're going to have a low cardiac output, less oxygen. Their kidneys aren't being perfused. And so their sympathetic nervous system is going to kick in. That increases their heart rate and it's going to start to constrict their blood vessels. And then the RAS system kicks in and that stimulates to help retain the fluids and cause more constriction of the blood vessels. Well, that's a big issue and we have to fix that because we're already holding on to a lot of volume and we're already backing up and now our body's going to try to hold on to more water and kind of constrict our blood vessels. So we're just having a double whammy. We have to fix this. So we're going to push meds. So the P is push meds. We're going to give diuretics because our body wants to hold on to fluids. We need to pull it off. So we're going to give them medications like Lasix, like Bumex. We're going to try to diurese them. And then we're probably going to give them morphine. Morphine actually is a vasodilator. It actually is going to help dilate the arteries. And then PO meds, we're going to be giving them medications to decrease that vasoconstriction, so that afterload SVR, which is your systemic vascular resistance. So we're going to give them some medicines to dilate them, and to block that RAS system, which is your ACE inhibitors or your ARBs. And we're also going to give them beta blockers to decrease that heart rate and improve that renal flow. So that's what we're going to be giving. Also, we talked about the squeeze of the heart. The contraction of the heart is being weakened from the muscle. So we may need a medication like an inotrope to help the contraction and the squeeze of the heart. So this is in the medication. It can be IV, it could be PO, it could be dobutamine, digoxin. Also a milrinone drip can be given to help with the contraction and the squeeze of the heart. And now we're going to go to E. We're going to eliminate fluids. We're going to put them on a fluid restrictions. At least 2 liters a day is going to be their fluid restrictions. And we have to reduce our sodium intake. There's so much sodium out there. The amount of sodium that the normal American takes in is astronomical. So we're going to reduce them to less than 1,500 milligrams a day. And that's going to be really hard because there's a lot of sodium in everything. There's sodium in over-the-counter medicines. So we need to make sure that they don't take over-the-counter cold medicines. There's Tylenol, ibuprofen has sodium in it. And there's also sodium in a lot of the foods we eat. The processed foods, the fried foods, the canned foods. So no canned foods can they eat, no chips. So they need to avoid those type of products. And then we're going to reassess. So we're also going to assess them because we also talked about the signs and symptoms. But when we do an intervention, we have to reassess for effectiveness. So we're going to re-listen to their vital signs. We're going to listen to their heart rate in their lungs. And then we have to do education. So again, education is really important. We talked about these patients having a low sodium diet. And so what we talked about is making sure they understand what foods and what over-the-counter medicines have sodium in it. And then also some of the things that they can do, which is If their blood pressure and their BNP is not getting better, we have to then call the doctor, because if we're reassessing the lab values and we're reassessing the vital signs and their lungs still sound coarse and congested and have crackles in it and their blood pressure still up and their BNP continues to go up, we need to let the doctors know. One of the other interventions that you can do is you can elevate the legs to decrease the swelling in the legs, and daily weights. So this goes back to the elimination of fluids. The daily weights are really important because this is going to see how much volume the patient has and if we are going in a positive direction with our interventions, if we're pulling fluids off. Because if they're continuing to have weight gains, we're not pulling enough volume off and we're going to put more damage and workload on the heart. So it's really important to go over that with the patients. And some other things you want to talk about, so interventions as well, is that you want to make sure they are on some type of DVT prophylaxis. This is going to be for everybody. Everybody in the hospital has some type of DVT prophylaxis. So they're either on some type of blood thinner like Lovenox sub-Q, or they need to have TED-HOs or SCDs on to make sure that their circulation continues. And never massage their calves. So people with heart failure, don't massage their calves. And so these are just some important things to know. And those are the interventions. Make sure you reassess for effectiveness. When you are not going in the right directions, that's your need to call the physician and report those findings. And I hope this all made sense. And that's the end of our lesson for heart failure.